Hello, everyone. We will get started in just one moment. Okay, well, good afternoon and welcome to Health Equity in Action, Libraries, Communities, Opportunities, a summit hosted by the American Library Association Social Responsibilities Roundtable, or SRRT. SRRT believes that libraries and librarians must center social responsibility by recognizing and helping to solve social problems and inequities to work for the common good. My name is Kim Reichenbach-Kretka. I am assistant professor in the Library and Information Studies program at Old Dominion University in Norfolk, Virginia, and I get to be the moderator for this session. I am joined by two others who are supporting us in this session, Hillary on tech and Julie in the chat. To enable captions, you can click More in the bottom right of the screen and then click Show Captions. Our session today will be recorded, and the recording will be available on our website within a few weeks. This session focuses on information access, health, and safety in the age of targeted legislation. And we are joined by four amazing presenters. Heath Umbreit, Adult Services Librarian at the Morrill Memorial Library, it will be presenting Resisting Censorship of Trans Healthcare Information. Mirandy Lee, a Morehouse School of Medicine Department of Pediatrics, will be presenting What Part of you did you have to destroy in order to survive in this world? How anti-LGBTQ legislation impacts our youth. And then Kaylisa Estes from Morehouse School of Medicine, presenting data governance and digital infrastructure for addressing contraceptive care deserts. And then Daniel Delmonaco, reference and instruction librarian at Levy Library, Icahn School of Medicine at Mount Sinai, will be presenting connecting healthcare providers and patients with LGBTQIA plus health resources in New York City. Also, full presenter bios are available on our website if you'd like to know more. And then we'll be taking questions for the panelists after all of the presentations have been concluded. So please, throughout the presentations, you can use the Q&A to pose those questions. You can do that at any time. And then please reserve the chat to relay any tech issues, resource shares, or appreciation for our panelists. So we will begin with Heath, and you can go ahead and take it away.
Okay, thank you. I'm going to go ahead and share my screen. Oops. Okay, so hello, everybody. Welcome. Thank you so much for joining today. And thank you to the Social Responsibilities Roundtable for hosting this summit. Before I dive in, you can access my slides anytime by following the URL tinyurl.com/resist-trans-health-censorship. I'd like to note at the top that I am not a doctor, a scientist, a health researcher, or a medical subject expert. However, I do have a master's degree in library and information science, plus about 10 years of practical reference experience in public libraries, personal and professional experience studying misinformation, specifically trans-focused mis and disinformation, and lived experience as a trans person in the US healthcare system. I'd also like to note that this session is neither comprehensive nor conclusive. Rather, this is a starting point to get everyone thinking about the issue and some actions that you might take going forward given your particular context. Because people aren't necessarily familiar with trans healthcare, I would like to give some background. It is extremely important to understand that among the people and organizations engaging in censorship of trans health data, the goal is ultimately to ban all types of transition care for all trans people of all ages. That includes not just medical transition care, such as hormone replacement therapy or surgeries, but also social transition care, such as manner of dress, haircuts, pronouns, and so on. Just 3 months ago, Kevin Roberts, the president of the Heritage Foundation, which wrote Project 2025, was asked how he wanted to address adult access to transition care. He answered very plainly, quote, outlaw it. I mention this because it isn't some hidden or secret plan. Legislators, scientists, and institutions involved in anti-trans advocacy have been saying outright for years that this is their goal. In healthcare settings and agencies in particular, this goal is rooted in the belief that being transgender is not an expression of natural biological diversity, but rather a pathology that needs to be fixed or cured. Since the presidential inauguration last year, trans-focused data have been deleted, suppressed, manipulated across virtually every federal agency, database, policy document, and website. By February 2025, less than 1 month after purges of trans-related data began, an estimated 8,000 web pages had already been impacted. Although researchers and advocates have worked to recover that data, it's likely that we'll never know the true extent of what was erased, lost, or changed. But it goes further than just the suppression of already existing trans health data. Censorship efforts also target the production and dissemination of future trans health data as well. Entire streams of trans-focused research studies, grants, and data collection have been defunded or canceled. And researchers and scientists are being pressured to adopt different terminology, methodologies, and focuses in order to get or maintain funding. For example, the federal government has ordered NIH to focus specifically on studying detransition and rates of regret among trans people. Finally, many institutions, including hospitals, schools, universities, and corporations, have voluntarily engaged in their own censorship, despite state anti-discrimination protections, and even though noncompliance has generally been upheld in court. Throughout history, information about trans people has been suppressed, and although every instance of censorship is a reflection of its particular time and place, we can learn from the parallels that exist. Before the US was even founded, white European settler colonialists engaged in the violent erasure of gender and sexual diversity among indigenous peoples. They targeted and murdered gender-diverse individuals, destroyed linguistic and cultural expressions and knowledge pathways, and imposed the Western gender binary as part of the ongoing project of white supremacy. Starting in the 1800s, white imperialism developed eugenics, a pseudoscience that claimed, among other things, that the Western gender binary was proof that white people were more civilized and therefore superior to people of other races. The tactics of cultural destruction, removal, and forced assimilation used against indigenous people throughout US history are similar to tactics that are now being used to delegitimize, isolate, and detransition trans people. A second parallel comes with the Nazi burning of Dr. Magnus Hirschfeld's Institute for Sexual Science in Germany in 1933. Hirschfeld was a cisgender gay doctor who opened the Institute for Sexual Science in 1919 in Berlin as a place of research, education, social refuge, and non-stigmatized medical treatment for gay and especially trans people. Over time, the Institute came to house an immense library of rare books, trans histories, and diagrams and protocols for surgical transition. It was at the time the largest collection of transition care resources in the world. In May of 1933, just 3 months after Adolf Hitler became chancellor, the Nazis sacked the Institute and burned more than 20,000 books. Although this was among the first and largest of the Nazi book burnings, and certainly the most famous and widely depicted in historical records, few people know that the books on the pyre here belong to the world's first trans clinic. This is how historical erasure happens. When even the greater context of destruction is censored, of course, so many people would come to genuinely believe that trans people are a new phenomenon and that trans healthcare is new or experimental. Finally, consider the Johns Hopkins Gender Clinic and the subsequent federal policies of the 1980s. This clinic opened in 1966, but was closed in 1979 for reasons greatly resembling today's censorship logics. Janice Raymond had recently published The Transsexual Empire, a trans-exclusionary feminist book arguing that trans people posed a threat to cisgender women. And Dr. Paul McHugh had been appointed director of psychiatry at Johns Hopkins, and he decided to close the clinic because he felt allowing people to transition promoted mental illness. Following this, in the early 80s, Reagan's HHS formally designated transition care as experimental, and therefore not covered by federal insurance programs like Medicaid and Medicare. And following suit, most private insurance companies also withdrew their coverage. That meant that transition care largely stalled. It couldn't be covered because it was considered experimental, but research evaluating its efficacy could not be conducted because it lacked funding. It wasn't until the Affordable Care Act of 2010 that transition care started to improve as the ACA expanded protections. The federal government removed the experimental designation in 2016, leading to better insurance coverage and more clinical care, but the delays and lingering stigma have had long-term impacts. Currently, we are seeing censorship tactics against trans health data that take two different but interrelated forms. The first tactic covers what most people are familiar with. That's data erasure and bans, which includes the physical erasure of data from federal websites and databases as previously discussed. The reclassification of preferred terminology, for example, referring to transgender surgeries as, quote, surgical mutilation, or transgender identities as, quote, gender ideology. And the delegitimization or suppression of evidence-based data, for example, the report commissioned by the Utah State Legislature, which found overwhelming evidence in support of transition care, and so has been buried and ignored. Or, as another example, the misleading anti-trans banners that were posted on the HHS, CDC, and FDA websites last year. This tactic also involves the cancellation of trans-focused research grants and projects that do not align with the current federal administration's ideological principles, widespread book bans and censorship of positive trans representation in libraries and other institutions, and the rollback of trans people's access to public spaces through legislation targeting access to restrooms and other facilities, athletic participation, trans-specific support networks, equitable healthcare, and even our ability to choose how to dress, what our honorifics are, or whether we have a right to exist in spaces where people opposed to trans existence might see us. The second tactic involves the creation, dissemination, and amplification of anti-trans pseudoscience and misinformation as a replacement for evidence-based data and best practices. This includes, first, concerted efforts to create an alternative scientific record and evidentiary basis in order to repathologize trans identities and re-stigmatize transition care. For example, the persistent attempts to validate and elevate a quote-unquote social contagion theory to explain rising numbers of trans youth. Second, concerted efforts to create an alternative funding stream that encourages ideologically motivated research. For example, a recently announced study at Northwestern University purports to research gender dysphoria in children and young adults, but is bankrolled primarily by individuals with ties to anti-trans activists and organizations. Third, efforts to replace or subvert accreditation, certification, and licensing standards. For example, Washington State University, the Michigan State Medical Society, and the Pediatric Academic Societies all recently came under scrutiny after formally credentialing curricula run by anti-trans hate groups posing as legitimate researchers. And fourth, efforts to change accepted standards of care, for example, by promoting conversion therapy as legitimate, to alter school and university curricula to prohibit discussions of trans identities or people altogether, and to weaponize federal regulations, for example, the FDA's recent warning that companies selling chest binders, which are compression garments, are violating the law for failing to register binders as medical devices. I hope that everything that I've talked about so far underscores why it is so important to resist these forms of censorship. Now let's consider some potential resistance strategies. Please note, I've used Bethany Karsten's work in the Trans Feminine Literature Review as a launching point for this section. Karsten outlines 3 Ds of data preservation. That's just distribute, duplicate, and document. And I've also taken the liberty of adding a 4th, discern. Our first strategy focuses on distribution or the accessibility of reliable information. Essentially, we want to make evidence-based data and resources as accessible as possible for as many people as possible. And we can do this in many different ways. In collection development, this pertains to selection, that is, making sure we stock our physical and digital collections with as much accurate information as possible, and with cataloging and classification, that is, making sure the information is correctly indexed and findable. For the former, I recommend using non-federal government alternatives to verify information. For the latter, consider using organizations such as Homosaurus, an international linked data vocabulary of LGBTQIA+ terms. We can also explore ways to expand access to our institution's resources by looking into open access practices and materials. We can participate in or support the efforts of people engaged in data rescue and preservation projects, for example, the Data Liberation Project or the Data Rescue Project. And lastly, we can seek monetary support from non-federal sources, with the caveat, of course, that we need to ensure funding is not coming from compromised sources. Our second strategy is duplication. Put simply, the more copies of a work that exist in different places, the less vulnerable that work is to erasure. Note that this is different from access. While many people might have access to a given book in the library ultimately owns the only physical copy of that book. So if the library deaccessions the book, that means the book is gone and therefore becomes inaccessible. Duplication is about enabling more people and institutions to hold their own copies of a work. To do this, we obviously want to make more copies of the work, for example, backing up materials onto sites such as the Internet Archive, or creating institutional repositories such as the University LibGuides linked here. Though, of course, with the caveat that we want to respect copyright and intellectual property. Once we make duplicate copies, we want to ensure that we retain those copies securely. For example, having contingency plans in case of institutional policy changes, website updates, staffing changes, and so on. Likewise, in the matter of collection development, it's worth revisiting standards around monitoring your collection, so making sure that copies are not being stolen, hidden, or defaced. And also deaccession, so considering whether to adjust weeding practices to potentially retain copies for a longer time. And lastly, consider how we can collaborate with other institutions and organizations who might be able to add duplicate copies into their holdings. The third strategy is to document, to create a record of present-day censorship for the benefit of people in the future. We can track changes that we're asked to make in our own work, such as changes in terminology or classification, methodology and focus, scientific standards, and projects or project proposals. As part of documentation processes, we can participate in initiatives such as defendresearch.org or perform data audits to identify longer-term patterns. We can track rejections of projects or grants, especially if the reasoning given is ideological. We can track whether, how, and why funding is compromised or weaponized, and how or where that produces biased results. And we can counter misinformation in a variety of ways. For example, by objecting when anti-trans activists or pseudoscience is platformed, legitimized, or accredited, by refusing to alter the way that we work or speak, by educating colleagues or members of the public about censorship, and so on. The fourth and final resistance strategy is to discern, to make sure that we can differentiate between evidence-driven and ideologically driven information, and to avoid radicalization in ourselves. It's crucial to learn how to recognize biased or incorrect studies or research practices, and to identify which organizations, researchers, sources, and methodologies are reliable versus which have been compromised. Many resources exist to educate people about accurate versus inaccurate trans-focused data and to track how pseudoscientific terminology continues to change and spread, and I've linked quite a few here. Additionally, professional medical associations often publish their official positions about different topics to rebut misinformation, and international organizations such as WPATH offer guidance and resources that are removed from the US information system altogether. It's also crucial to guard against becoming compromised ourselves. While I recognize that our current circumstances are precarious, I encourage everyone to refuse to comply with external censorship efforts and to be really intentional about refusing to censor yourself. If at all possible, do not work with colleagues or institutions that are compromised. In other words, don't give them the benefit of your good reputation, and to the best of your ability, prevent your particular institution or colleagues from becoming compromised. Push back against repressive policies, urge others not to work with compromised researchers or groups, and hold people accountable if they engage in censorship. This slide includes several references that I used to inform this presentation for anyone interested in learning more. If you have questions or you want to chat, please reach out anytime via email or through my website. As a reminder, you can access my slides at this URL. Thank you so much for your time and attention, and I will now pass the mic to the next speaker.
Excellent. Thank you so much, Heath. You've started us off very well, and I'm very excited about our next presenter, Mirandy. You can go ahead.
Okay, I'll share my screen. Oops. Can everyone see my screen?
Yes.
Okay, great. Amazing presentation, Heath. I am a medical professional and I agree with everything that you said. So hi everyone, my name is Mirandy. I'm a pediatric resident physician with Morehouse School of Medicine, and today I'm going to be talking about how anti-LGBTQ legislation impacts youth specifically. So anti-LGBTQ legislation has been almost exponentially increasing over the past few years. And in this presentation, I'm going to focus on the issues in bold since they mostly impact LGBTQ youth. So sports bans, gender affirming healthcare bans, and curriculum censorship. But there are definitely many other types of anti-LGBTQ bills. And we are currently at 525 anti-LGBTQ bills so far this year, and we still have months left for that number to get even higher. So here's a map of all of the anti-LGBTQ legislation that's been introduced this year. Darker purple means a higher number of bills. And as you can see, Texas is at 0, but that's because their state legislature only meets every other year. So even without Texas, there have been 525 anti-LGBTQ bills introduced, and next year there's likely to be even more. So the first issue I want to talk about right now are sports bans, which are kind of a hot topic. So only 14 states have policies that allow children to participate in sports consistent with their gender identity. And meanwhile, 27 states have banned transgender children from participating in sports consistent with their gender identity. And these bans primarily target trans girls and trans women competing in women's sports. So most of these bans rely on a very vague definition of biological sex, and they propose accusation-based testing. So basically, enforcement usually begins when someone like a coach or a parent or a competitor decides an athlete doesn't look right. And so how to verify someone's sex isn't usually delineated in these bills, but it will definitely cost taxpayers money. And one study estimated that to verify an athlete's biological sex, it could cost $10,000 or more per athlete, depending on what tests are done. And other bills in similar states propose incredibly invasive ways of verifying someone's sex, like genital exams. And obviously, this endangers all girls in sports, especially since most of these bills propose accusation-based testing. This is obviously really subjective, and not to mention invasive and also racist, as many of the women who have been accused of being trans are Black and brown women, which is no coincidence. So one argument for banning trans women in sports is that trans women supposedly have an unfair biological advantage. But biological differences exist everywhere in sports, especially at a young age. So let's talk about Michael Phelps. He's one of the greatest athletes of all time. He has a lot of biological advantages. He has a wingspan that is greater than his height. He has hypermobile joints. He produces half the amount of lactic acid as other athletes. But no one says it's unfair that Mr. Phelps gets to compete in sports when other people don't have these advantages. I don't know if anyone recognizes these athletes. The one on the left is Caitlin Clark. She's 6 feet tall. She's cisgender. She plays for the WNBA. And people say, wow, she's 6 feet tall. She was made to play basketball. And the girl on the right is Harriet McKenzie. She is a transgender athlete who plays for a small college in British Columbia. And she's also 6 feet tall. But people often immediately say that it's unfair for her to play. So women and girls do face significant barriers in sports that have nothing to do with including trans people. You know, inequitable facilities, inequitable pay, abusive coaches, harassment. Just a few weeks ago, both the women's and men's USA hockey teams defeated Canada to win gold in the Winter Olympics. And our president congratulated only the men and invited them to the White House and said that he had to invite the women too, otherwise he'd be impeached. So for additional context, the last time the women's team won gold in the Olympics was just in 2018. And the last time the men won gold was 46 years ago against the Soviet Union. And the lowest paid men's hockey NHL player earns over $700,000 over a season. But the highest paid women's hockey PWHL player earns only about $100K a season. So the men's team ended up going to the White House, the women's team declined. But this all just goes to show that women's sports are not suffering because trans people might be included. And I would love to ask sponsors of these types of bills what efforts they've made to address actual issues harming women and girls in sports. So let's move on to another hot topic right now, which is gender affirming care. The most common gender affirming medications that are prescribed are puberty blockers and hormone replacement therapy. And even then, a pretty small percentage of children actually start taking these medicines before the age of 18. These medications are safe, effective, and they have a positive outcome on trans children's mental and physical well-being. And the decision to start these medicines is not a light one. It takes a lot of conversations, a lot of meetings between the patient, the parents, and the providers before we decide to start medication. And it's a shared decision that is made with a lot of consideration to each child's unique situation. There is this fear that children under 18 are undergoing gender affirming surgery, which is irreversible. But the reality is very, very, very few children have gender affirming surgery before the age of 18. Way less than 1% of children with a gender dysphoria diagnosis. The most common gender affirming surgery is what we call top surgery, where the breast tissue is reduced or removed. And you know what is a very similar, if not identical, surgical procedure that is done at way higher rates than top surgery? Breast reduction for cisgender men with gynecomastia. In fact, 97% of breast reductions performed under 18 are done on cisgender men. And it's also a form of gender affirming surgery. So as you can see, legislation blocking gender affirming care among trans youth is not about protecting children, but it's rooted in hypocrisy and stigma. And it seeks to address a problem that actually doesn't exist. Again, gender affirming care is safe, effective, evidence-based, supported by medical science for children and teens. And all of these national and international medical organizations recognize the importance of gender affirming care for children and teens, including the American Academy of Pediatrics. All right, the last topic I'm going to talk about is curriculum censorship, or as you may have heard of them, the Don't Say Gay laws. So in 2022, when the law was first passed in Florida, it was really vague. It prohibited schools from using a curriculum or discussing topics related to gender or sexuality. And this included talking about your LGBTQ family members. So if a kid in school talked about their family with two dads, a parent could sue the school for inappropriate discussion of sexual orientation. And since then, 16 states have introduced similar bills and 7 states have passed these bills. On top of all of this, these laws are often coupled with other laws that forbid teaching about structural racism, slavery, critical race theory, all on the grounds that these concepts make other people uncomfortable. Well, if we're talking about gender sexuality making people uncomfortable, imagine how uncomfortable LGBTQ youth feel under these laws. Anti-curriculum laws send a message that LGBTQ youth are not accepted or supported, and they imply that there is something inherently wrong with LGBTQ youth. In fact, LGBTQ students who find their school to be LGBTQ affirming report lower rates of depression and suicide. So when lawmakers treat LGBTQ topics as taboo, it leads to the existing stigma and discrimination that puts LGBTQ youth at greater risk for bullying, depression, and suicide. 41% of LGBTQ youth have seriously considered suicide in the past year. And so I want to talk a little bit about minority stress theory, which says that individuals with stigmatized identities face increased levels of stress than that of the general population. And for LGBTQ youth, this can be due to anti-LGBTQ policies, bans, rejection, discrimination, etc. And studies have shown that increased minority stress is associated with higher blood pressure, anxiety, depression, suicide, substance use, but even things you might not expect like asthma and cancer. So I'd like to circle back to the title of this presentation, which was taken from a fabulous book by Alok Vaid-Menon. And they ask, what part of you did you have to destroy in order to survive in this world? And I think back to the 41% of LGBTQ youth who have seriously contemplated suicide. And I think about the ones who destroyed a part of themselves or who didn't survive. Would they still be here today if they lived in a less hostile political or social environment, if they went to a more accepting school, if they got to play the sports that they loved? I don't know. And I know that was a lot, so I'm going to take a little breather and talk about something a little lighter, and that's Mars. So, for those of you who don't know, Mars is a baby pygmy hippo who was born in Kansas, and he's very cute. And I highly recommend following him on social media. Okay, I know that was really heavy. So, back to the presentation. At this point, you might be wondering, well, what can I do as an individual, as a community member, as a member of society? So, for this last part, I'm going to talk about the socio-ecological model. You might have heard of this model, but it basically says that an individual's health is influenced at multiple levels. And I'm going to end this presentation by talking about what you can do at each one of these levels to help LGBTQ youth. So first is the individual level. You can educate yourself. Educating can be exhausting for people with marginalized identities. So I encourage you to learn from others with lived experiences. You can never learn all there is to know about someone's identity, but you can try and learn as much as you can with a curious and an open mind. What can you do at the interpersonal level? First, you can wear your pronouns. You can wear your pronouns, and also don't be scared to ask for a person's pronouns. We want to encourage the families of our LGBTQ youth to support and accept their child, which can be difficult for some folks, but that conversation is something that can be initiated in the setting where you work. Encouraging families to be loving, supportive, and accepting of their LGBTQ child in an empathetic, affirming, and encouraging way. There are already a lot of affirming spaces that exist within our organizations, and there are a lot of resources that we can recommend and collaborate with. We can promote and implement pronouns in the records that we keep. We can promote anti-bullying and anti-discrimination policies. We can hire LGBTQ employees so people see themselves reflected where you work, and we can continue committing ourselves to DEI. Let's talk about community. I love seeing our community leaders visibly supporting the LGBTQ community. And when we talk about community, we also need to talk about online communities, making sure we're liking and sharing and TikToking accurate, relevant information to educate our communities. Misinformation is everywhere, so be sure to do your research. There's a lot we can do on the policy level. You can write and talk and meet with your legislators. If you live or vote in one of these states, there is currently an anti-LGBTQ bill that has been introduced or is advancing right now in your state legislature. And most importantly, vote. I know we probably voted in the last election, but it's equally, if not more important, to vote in your state and local elections as well. So make sure you vote for someone who you want to be your voice. And finally, there are societal changes, and these are really broad: ending stigma, changing norms, breaking barriers. All of these things require all of us in order to succeed. And we want to create a society where our LGBTQ youth feel supported, accepted, and loved, where they don't have to live in fear, where they don't have to hide, and where they don't have to destroy a part of themselves in order to survive. Thank you for listening to my presentation, and feel free to email me, and I'm happy to take any questions at the end as well.
Awesome. Thank you so much, Mirandy. And I appreciate your conclusion, focusing on what we can all do on many different levels related to these issues. So thank you. And yes, a good reminder, if you audience members have questions, go ahead and put those in the Q&A as we go, and we'll get to those at the very end. Without further ado, Kaylisa, you're up.
Hi, everyone. I'm going to share my screen. One moment. Perfect. Alrighty. Can everyone see my screen?
Yes.
Perfect. All right, so let's get started. My presentation is Data Governance and Digital Infrastructure Addressing Contraceptive Care Deserts. A little bit about me. I am a doctoral student at Morehouse School of Medicine. Currently, I am focusing on my research agenda, which is centering women's reproductive health and the social determinants in access and outcomes that provide equity within that space. I'm also a precepting medical social worker at Emory University Health System, and I am licensed to engage in clinical care with my patients. I'm also a published scholar, and I'm an advisor and reviewer for the Global Journal of Medicine and Public Health. And my long-term vision is to drive innovation within the field of reproductive health mainly through clinical access and applications. So I would first like to frame the issue, access, information, and population health. And so a little bit about this area, excuse me. Access to reproductive care is shaped not only by digital access, but by legislation as well. Information within this area is the gateway to care, safety, and autonomy, and disenfranchised population face compounded barriers. So the impact that we're seeing currently within our research, 19 million women live within contraceptive care deserts in the United States alone. Within those 19 million, we have unintended disparities that are occurring. We have higher unintended pregnancy rates as well as higher unintended STI rates within regions that can be considered contraceptive care desert or at-risk contraceptive care regions. Within those unintended disparities, we have population disproportion. So as we discussed within previous sessions, disproportionate impacts are included on Black, rural, and low-income populations. And then social determinants are our primary areas of focus. So social determinants of health are outcomes rooted in structural inequities and environmental inequities. And so we are going to now move on to data infrastructures and assessing quality improvement within this area. So areas of failure that I am primarily seeing within my research, we have fragmented systems. So none of our systems that we're engaging in are collaborating with one another. The CDC is not collaborating, HRSA grants are not collaborating, the US Census is not collaborating in terms of data engagement within reproductive care. Within those systems, data is also not being disseminated to physical organizations. And so with lack of data, we have lack of information, and then we also have lack of access or funding. And so because we do not have areas of real-time integration, we're not acquiring disease prevention at accessible rates. So for instance, if there is an outbreak within a region, we do not have real-time data to ensure that we adhere proper resources to that region. We also have limited predictive modeling. So as I discussed earlier, without lack of access and understanding, we cannot predict when incidents are going to occur socially, and then we cannot engage mobile clinics as well as educators and other healthcare personnel to those areas. And so we are having very reactive systems instead of proactive care systems. Preventative care is not being able to occur within contraceptive care spaces. And so we're having to disseminate informations as well as products and care items to individuals in a reactive base versus what if we could mail you a package? What if we can center a clinic within your space so that way you have a physical place to go to? And we also want to make sure that if there is a higher density population within a region, that we have enough healthcare officials to reduce any health disparities that come with staffing or workforce shortages. And so some solutions that we are reviewing within our research, integrated data platforms. So digital care experts are ensuring that clinics, policy, data governance, and population data are all within a data platform that engage contraceptive care. Within those data platforms, we want to ensure that geospatial mapping also occurs. So we would love to engage various forms of learning, visualizing contraceptive care deserts in a digestible format for public audiences. If we're only speaking to academics, we're not engaging those that need care. And so making sure that we can visualize it for them, ensuring that we have language that they are understanding and are able to engage in, and also ensuring that content is palatable for populations that are most impacted. And so predictive analytics will also ensure with care delivery and ensure that we have proactive interventions that can occur within these regions. And last but not least, when we have predictive analytics, geospatial mapping, and data platforms, we can create decision making that includes reductions in unwanted outcomes that is data driven. And so, how can libraries engage in this process? We are going to overview information as intervention points to care. So some of our intervention points that we would love to engage in, trusted community information hubs. So we want to ensure that libraries are assisting with reducing misinformation within contraceptive care. And we also want to ensure that libraries are assisting with telehealth navigation. This would make libraries digital access hubs that contraceptive care figures can engage with, as well as audience members. We also would love for public health officials to engage in reproductive health sessions. So education access will begin to occur across generations with varying reproductive health sessions. We would love each of our sessions to be age appropriate. We would love for them to be informed, and we would love for them to learn about various aspects of contraceptive care, including preventative care, autonomy, decision making, and proactive engagement with others. And so, last but not least, we would like funding attributes to outreach, tech access, and disease prevention programming. So within our next slide, we'll overview friends of our library and associates that can engage funding within these initiatives. And so some of our key industry partners that we would love to engage with at Morehouse School of Medicine, myself, and other clinical partners include education, training, and research. Education, training, and research provides age-appropriate education and assists with training future health educators. I was actually a fellow at Education, Training, and Research. We conducted media campaigns as well as digital health engagement sessions. Also, we did community-based work in California and street-based work where we engaged with the public on a day-to-day basis to ensure that they were engaged in training in contraceptive care. One of our favorite partners is Planned Parenthood. If you are within the reproductive health space, you understand the importance of Planned Parenthood and the service offerings that they provide within their clinic. Planned Parenthood provides clinic access as well as physical infrastructure to comprehensive care. Not only do they provide trans-affirming care, but they also provide STI care, miscarriage and abortion care, and health care that serves various audience members and their identities. Also, the Society for Family Planning. The Society for Family Planning provides research, fellowships, and grant funding towards contraceptive care initiatives. Each of their fellows within their industry partnerships engage in specific projects that target contraceptive care and family planning. Some of those projects include the reduction of STIs within communities. They've also engaged within the Black maternal health crisis, and they've also engaged in understanding the way that the medical field has either harmed or befriended contraceptive care in varying ways. Last but not least, one of our favorite digital contraceptive care platforms are both Aid Access and Hey Jane. These platforms are new and renewing the field of contraceptive care digitally. They provide not only products that engage targeted audience members, but they also provide abortive care, contraceptive care, and counseling that can ensure everyone gets the help that they need within the times that they need. And so I am a data scientist and I love to present facts and figures. Each of these graphics were created by me using the CDC Title X programming and National Survey of Family Growth datasets. So for our first graphic, I outlined the total reported cases of STIs from the years 2015 to 2024. As we can see within the year of 2020, our levels went down. Most of our research has assessed whether or not that figure is accurate. a lot of our conclusions are coming to one, people were not able to engage in care during that time during lockdown. So there may have been a reduction of numbers. Um, Also, clinics were closed during that time and lots of funding cuts occurred. So data was not being engaged. And also during that year, our administration created cuts on access to contraceptive care spaces or pages digitally. We see an uptick within these levels in 2021 after restrictions have were lessened, and that specific figure stayed the same within 2022 and 2023. 2024 data shows a downtrend, and we are hoping to increase that downtrend in the future. To include information from the previous figures, here is a graphic that I created that lists contraceptive care desert risk by state. Each state has its own story, and just because someone has a low rate does not mean that they do not deserve access or care, or there are not other social factors that are impacting that region. For instance, Louisiana, it is where my roots are, it is where my family is from. They have a high amount of access, but they still have a high density and population of STIs, of personnel that have STIs. This is due to lack of sex education, lack of understanding best sex practices, and lack of engagement within care officials to ensure that the public has the resources that they need, as well as clinic access. And so due to this, they are one of the states that sometimes get overlooked within the contraceptive care desert conversation, as well as other states that are grayed. So this is a graphic. We are still doing some assessments on why each state has the profile that they do socially, but Louisiana is a really good state to a case study to assess why each state has a different story and how we can engage contraceptive care strategically. Other states that you can see that may have low access and high STI rates also have very restrictive legislation surrounding contraceptive care, abortive care, and LGBTQ care. One of those states that you can see right there is Texas. However, California has differing legislation, like what I said earlier, but they have a higher population density, so clinic access is not available to those populations as needed. Um, Going to our next slide, these are the contraceptive care methods that were ever used among all women aged 15 through 49, race not included. And so one of our highest percentages is male condoms, as well as the pull-out method. As we know, those are not very effective methods to reducing both STIs and unintended pregnancies, and as well as other birth control options and contraceptive care options that may be more apt to doing so, have negative histories or negative associations, i.e., sterilization, i.e., the birth control pill. And we can see that across varying health histories. Black women's reproductive health history has a contentious relationship with some of these methods. So it's important to include health histories as we move forward and engage with varying populations. Understanding the social aspects that impact the population's ability to engage with care is important. And going into communities and engaging in communities from an empathetic lens and a historical based lens is important when engaging new products such as PEP and PrEP, and new forms of birth control. And so some highlights from the data that I just discussed. We compared downtrending and behavioral habits amongst both states and varying populations. We also want to highlight how education gaps contribute to disparities and the importance of sex education within regions, and within public health spaces. And then public awareness is critical for informed decision making. If you don't know that you have an option, you cannot select the option. And so it's important for the public to be aware of the varying options that they have with contraceptive care, digital care, and information gathering. And then last but not least, product method and clinic access assist with positive outcomes. Having physical clinics is equally as important as having digital clinics. As we view across age groups, our elderly populations are not as good with digital access, but they still have contraceptive care needs, as well as our younger populations who are more vulnerable to at-risk engagements such as sexual assaults and elder care violence. And so these are important things to understand as we're engaging in clinic access and wanting to understand where do we strategically place physical clinics and how do we engage digital clinics across age groups. And so last but not least, a call to action and ways that we can assist. First, we have to shift. So we have to engage a need for more predictive and data-governed systems with legislative protections. It's not enough to have predictive systems and non-governed data-governed. It's not enough to have predictive analytics and non-data governed systems. Lack of data governed systems can have situations occur such as eugenics and sterilizations. And we want to ensure that we have legislative protections so that way concerns such as Roe v. Wade and the dissemination of Roe v. Wade do not continue to occur across our landscape. Also, it is going to be important for us to expand. So we want to expand simultaneously, both digital and physical access. And then it's important with gap offsetting, cost initiatives, and revenue generation. We have seen some interesting work within the field of Planned Parenthood in California. They did an audience survey and realized the habits that some of their audience members were engaging in, and they have offered things such as Botox to offset the costs of abortion care within the region. And so revenue generation and the creation of products is going to be important as we expand access across states, and understanding the social profiles of those that engage with their care is equally as important. Last but not least, we have to both engage and invest. So engaging community institutions as intervention points, areas such as the library. I'm a huge fan of the library, if you all didn't know. But engaging areas such as the library, physical clinics, public health officials, educators, and academic institutions will be important in creating community-based interventions of care, and also being physically engaged with your community as well. Your lived experience and your identity is important in shifting and expanding contraceptive care and educating those that may need that care the most. And last but not least, investment. Investing in infrastructure, partnerships, and education is super duper important. As we move forward within this journey, revenue streams and investment streams will be important to expanding and shifting. Venture capital and industry-based partnerships will be as important just as governmental engagement within the areas. As we can see, governmental engagement hasn't always been the best, so it will be important for us not to engage just regionally, but globally with our venture capitalist partners, as well as our academic institutions who may be able to create partnerships with other donors and investors. And so that was my presentation. Here is my contact information. I'm also the founder of a contraceptive care website, www.everythingaok.org. Counseling and information, as well as resource gathering, are provided on that website. And also the link to our partners are also found there. My LinkedIn is below, and these are some of the references used within my presentation. So thank you, and have a great rest of your day, and I'll pass it to the next presenter.
Awesome. Thank you so much. I really appreciated the data visualizations that you created. And so thank you for sharing those with us. And then last we have Daniel. So I'll let you go ahead and take it away.
Great, thank you. Thank you to all the previous presenters. Has been such a great session. I'm glad we all got lumped together, and I can tell why, because I think this is like a great in conversation with each other opportunity. Let me just, where's that present button? Okay. Can everyone see my actual screen or this weird Microsoft presentation? Mm, where is it? There. Okay. Slideshow from beginning. Can everyone see? Am I sharing the presenter view or the
It does look like the presenter view.
oh, how do I not do that? Okay.
Do you have more than one screen that you're working
I
with?
do.
My guess is it's tied to that, but I don't know unless I was sitting there.
Okay.
I don't know if our
Sorry,
tech
one
person
sec.
has info. Oh, it's no worries.
Okay, I
We're a
figured it
little ahead
out.
of time, so we're good.
Okay. How's that?
Looks great.
Okay. Thank you. Thanks, Kim. Okay, so I'm Dan Delmonaco. I'm reference and instruction librarian at the Icahn School of Medicine at Mount Sinai. I'm in New York City, on the Upper East Side. And then this presentation is connecting healthcare providers and patients with LGBTQIA plus health resources in NYC. So I'm focused mostly on the LibGuide I've been working on really for the last year. I came into this position in about January 2025. So coming into this position, one of the first things that sort of happened politically, February 2025, here's a sampling of many of these headlines. U.S. health agencies scrub HIV other data to remove quote unquote gender ideology. Trump administration purges websites across federal health agencies. U.S. health websites data sets taken down as agencies comply with Trump executive orders. CDC scrubs research databases referencing sexual orientation and gender identity. So CDC, with this new leadership that came in last year, is really just taking down all sorts of LGBTQIA plus related health data, among other things. And as a medical librarian, what do we do? Because for so many of the like go-to resources I had, we had links to CDC websites, all this data and links that now just basically look like this, where they either say the page you're looking for was not found, and you just are left with a screen, or almost even worse, this is the page Health Disparities Among LGBTQ Youth. And so if you go to it, it still says this nonsense where you can kind of see these transphobic buzzwords and dog whistles like this page promotes gender ideology and things like that. So sort of like as a librarian, as an LGBTQIA plus profession, like health professional, not really going to be directing my providers, any patients to these resources for this relevant information because now it seems like untrustworthy. So what does a medical librarian with access to a LibGuide? So I inherited a LibGuide that was LGBTQIA plus health, pretty broad, and most of the links on it were CDC links. So kind of was reviewing what LibGuides I had access to, found this one, and it was mostly sending to either broken links or links with inaccurate information. And also my background from my PhD is in LGBTQIA plus health information seeking. So knew that kind of this was an opportunity to really have some sort of direct information intervention, at least with the like Mount Sinai community where I'm at in my hospital and med school. So this is my solution using my subject area expertise to revamp this existing guide that I had. So I think it was gonna get put in the chat. Thank you if you're able to do that. But so this is what it looks like now. I wish I took a previous screenshot. I didn't because I didn't think I would be presenting on this process. But this is what it looks like now. It did not look like this when I inherited it. But this really, yeah, just became kind of like a project to address this direct attack on information access for relevant LGBTQIA plus health information. what to do to sort of create a guide that I wanted to be inclusive, accurate, and most importantly, really usable, especially by our providers and their patients. So these were sort of the three major steps I took. Drawing from my previous participatory design work, as part of my dissertation research, did these design sessions and focus groups over years with LGBTQIA plus individuals, many of whom were youth and adolescent. And then I sort of have their feedback up here and ready to go. So used this to really inform the LibGuide categories and the content that I put on the page. And then revising and structuring the LibGuide based on who my imagined users were. So using this concept that I'll talk about a little later to really think about who is going to be using this website, this LibGuide, and how can I make sure that it's basically set up in the most user-friendly way for who I think would actually be using it the most. And then, like I mentioned, the real motivation was identifying alternatives for these topics that I'm creating and this content that I knew I wanted to be on there when I knew CDC and NIH health content at this point really wasn't trustworthy or accurate for a lot of these topics that I wanted to include. So just to talk a little bit about my past work that informed this, these are just some examples of the papers I published on this work, and they're linked at the end. But basically, I did a lot of work on how LGBTQ youth were looking for health information, specifically sexual and reproductive health information in some of these projects. So, and then the community engaged participatory methods paper, you can see that's really where we did a lot of the participatory design work in that project. So here's an example of what kind of that looked like, if anyone's not familiar, but it really comes from like user experience, sort of was the world that I took a lot of the methodology from, and thinking about, we knew with the community organization I was working with on this research that they wanted to revamp their youth advisory board that we were working with wanted to revamp the website. So that sort of turned into, along with them, developing this website through some like user experience testing that included focus groups, these design sessions, and then the actual like testing and development of this website with our design team that we had as part of the project. So on the left are two examples of some of the artifacts from those participatory design sessions. So this was really these specific examples were how like what content should be included on a potential LGBTQIA plus health website, and how should that like basically homepage of the website look. So you can see some examples of top. So they said there should be a for provider section and a for youth section. Beneath it, there should be a new resources section, and then it should be split into parents, youth, providers. So just an example of thinking about how to structure these resources. And then you can see how that informed this. On the right is the prototype of what the actual resource directory we developed looks like. So that's like very quick participatory design review. And to think about, so I have that sort of participatory design information, and then also this idea of imagined audience. It's also, if you're in like UX world, like the idea of creating personas for different users is a pretty similar concept. But Eden Lit, this is the definition I like, says imagined audiences are the mental conceptualization of the people with whom we are communicating our audience. So in this case, for this LibGuide that I knew I wanted to revise, I knew my audience would mainly be healthcare providers who likely had LGBTQIA plus patients who either needed to find information, were encountering like these different populations for their first time and needed more information, or these providers might be looking for getting their own patients information. So thinking about also that patients might be navigating this website, not just those with healthcare expertise and some type of education in that area. And also knew that I wanted this to be pretty like geographically specific. So thinking about how I can connect providers and their patients with specific NYC resources that could hopefully meet whatever need like ASAP. And then thinking also how this audience will be using it. So thinking about if there were specific communities that that I wanted to include, needed to include that weren't represented on the previous iteration of this. Some maybe explanatory information that providers might be using for themselves, but also could be able to share with their patients about certain topics on this guide. And then also, again, finding relevant New York City resources for a lot of these specific communities or health needs. So these were sort of the prompting questions now that I used to inform this LibGuide creation. But thinking about why are the healthcare providers accessing this resource? So like I said, basically, many of them probably are either trying to educate themselves or find material to educate their patients, to pass on to their patients. I wanted to think about what categories within the LibGuide, which I'll show in a couple slides again, would be most readily usable. So like if they are thinking like, oh, I have a patient who needs PrEP, where would I quickly be able to go to a tab and find like that exact information? So that sort of is, that's what I mean by readily usable for these audiences. What types of resources can providers learn from, but also share with their own patients? So wanting to make sure that there's the kind of like technical health side of things, but also information that might be accessible to patients who are maybe youth and might not have like that high scientific reading level. So having a mix of sort of reading level, engagement level, so that it's not just like heavy medical text for providers. And then also what alternative sources to the CDC and NIH exist for LGBTQIA plus patients. So what are these sources that could replace a lot of the links that are now defunct? So thinking about focusing on state departments of health. So in New York and New York City, we have a lot of great online LGBT health information. So linking to that. And then also kind of larger than just federal, thinking about like WHO, World Health Organization, or UN or EU resources too, that are still like scientifically backed and credible and evidence-based. And then thinking about also a lot of LGBTQIA plus NGOs that do their own research or are having this information in more verified and credible ways. So that's really how I thought about addressing replacement of the CDC links. So just to walk through some of these topics, that blue text, those are the different topics that you would see on the homepage. So this is what the LGBTQIA plus resources in NYC looks like. I wanted to think about, okay, if I am quickly trying to recommend to a patient a provider to go to or a clinic to go to, that I decided wanted to be first because I thought that might be what most providers would be going to this page for, at least like in patient visits or while like on Epic talking with patients. So highlighting that and then also trying to have a diversity of resources. For example, like focusing on insurance enrollment, that was something I added with so many people getting kicked off their health insurance within the last year. So like finding resources that might tie to like real world events that would impact the population. And then also wanting to have some sort of starting point for maybe those providers, maybe parents, people who might be using this that are kind of like totally like square zero, like what does this acronym mean? So having sort of an intro page for them. And then also highlighting some areas of LGBTQIA plus health that are often left out of these larger conversations. So like intersex health and asexuality are two. Those are identities that have their own sort of health issue, or those are identities that impact health issues in sort of their own unique way and might be different from other components of that LGBTQIA plus acronym and how asexual or intersex people are interacting with the health system. So wanted to make sure to highlight those. That was something that came up in the earlier like sessions I did back in my PhD program. So this was an opportunity to really highlight some of those resources. And also figured that that's something that healthcare providers often aren't getting in med school or other areas, so that they might be, no matter their training, might be lacking information on. And then, and then just highlighting also thinking about what about researching with LGBTQIA plus populations. So tried to highlight, we are a med school, so we get a lot of requests for research on various LGBTQIA plus populations. So thinking about what research data is available for potential researchers, and then also I included many resources on how to conduct information with this population as a marginalized population that has kind of its own safety and privacy needs. So there's the guide. So what do we do now? So I really focused on getting a lot of feedback and review from all sorts of people who might be interacting with this. So librarians, providers, social workers, and then some contacts at nonprofits. And that was really helpful and generative in getting it tightened up and adding resources that I didn't originally think of. And then relatedly, share now that going through that feedback process, but then also thinking about, okay, now that it's done, how do I actually get it out there? So we have an employee resource group, which is an LGBTQIA plus affinity group at Mount Sinai. So I've shared it with them, and that has a lot of our practitioners who are both LGBTQIA plus themselves, but also working with that community as providers. So that's been a really great way to share this resource with people who are actually consulting it and using it. Also sharing it with providers and nonprofits outside of Mount Sinai. And then sharing with friends or colleagues that I have in the LGBTQIA plus community. So I've shared it with drag queen friends, friends who are providers, friends who are social workers or teachers, and yeah, just being like, here's just so you're aware, if any LGBTQIA plus health issues come up, here you go. Here's a stable URL. And the fact that it is a stable URL hosted by my institution means that it can be pretty easily shared and also updated and revised and doesn't need to change the URL. So I think that's been like a unique benefit of this LibGuide format and being able to host this information on a LibGuide. That isn't possible intervention for other librarians. To really like utilize that stability of having a guide in one spot. And so my final takeaways, ideas. So my favorite book I read in grad school, I think any librarian should read it, is Sorting Things Out by Bowker and Starr. And they say the only good classification is a living classification. So I think it's really important, especially for LibGuides, like I mentioned, the fact that they can be pretty easily updated and can be dispersed pretty easily. So I think that is really something we can utilize. And the fact that it is like the choices I made about what to include is very much like living. It was choices. It has my own biases and my lived experience as to how I decided what topics to cover. But it is, I recognize that it like is very much living, and I'm happy to add new categories, update categories, add new content, and I've been adding new content as new things have come up or as new research has been released. Or I've been made, or often we'll have friends send like, hey, do you have this on your guide? And being able to add that pretty quickly. So I think that's also part of talking to your imagined audience. So now that it's out there, getting the chance to talk to people who have used it and getting more feedback has helped inform what I can add to it or what might be missing. And then I think also, like I said, this came from trying to be responsive to information loss and suppression. So thinking about as information professionals, how we can find alternatives that are relevant, evidence-based, credible resources. This would really pushed me to think outside of like, okay, I can't just go to the CDC. We have to get a little more creative. I also wanted to highlight there are like these data recovery efforts. Restored CDC is one. So if you are someone looking for what was the CDC Gov page saying previously to this current administration, that's a recommendation. They kind of captured the website before everything went down and was changed. And then also just here, like I feel like I've been trying to talk about this guide more just to promote it. I think I think it's now been put in the chat, so it's there. And please feel free to share far and wide, make recommendations. If there's anything that you think I should add, feel free to like copy. If you're a librarian and want to like copy the categories or something, go for it. yeah, just want this information out there. Yeah, thank you. Looking forward to any questions anyone has.
Awesome. Thank you so much, Daniel. I loved seeing the deliberate and thoughtful approach to the construction, curation, but also the dissemination and then refinement of your LibGuide. So
Thank you.
thank you so much for sharing that. I also have not read that book you said every librarian should read, so I'll get on it. Um,
I'll
and
put that on the
I
chat.
Okay, awesome. And as we wait to see if there's some questions from the audience, I'll go ahead and give you guys one of mine. You all, Daniel kind of noted how it was great you were all in the session together, and I agree. You all have such deep knowledge around a lot of connected and also overlapping issues. So I wondered if, after hearing each other present, if you had any questions, comments, or ideas for your fellow presenters coming from that deep knowledge that you have.
I'll ask a question. Within your profession, and then I'll answer it. But within your profession, what do you feel like has been the hardest barrier to combat within your area of expertise? Me personally, within the field of social work, it would be differing views within the community, especially within marginalized identities, LGBTQ identities, as well as race and body and size. And so those would be my top three. But within your field of expertise, what do you feel like have been the hardest barriers?
I can go. I think specifically for this project, it was definitely uh, I was I think warned about a lot of potential pushback. Like if anyone was gonna see this from like higher ups, like would they be worried to even have this like associated like with this organization that's getting federal funding, et cetera. So I think that was like navigating that warning slash like tension from higher ups that like, oh no, you might like, are you sure you want to do this? I think like yeah, I guess navigating sort of like a preemptive acquisition to like hate and like these evil powers that exist like just because like it might get us in trouble doesn't maybe that doesn't mean that we shouldn't try it at least. So that's sort of like the tactic I took. But that was like something that was a major hurdle issue.
think, thank you for the question. A really, really great question. I think for me, the hardest thing is that there's just so much information out there. As somebody who concentrates on anti-trans mis and disinformation, I have trouble keeping up with everything. And like I'm dedicating time and effort to doing it. And so it is very difficult to concisely talk to people about it who have also been exposed to all of this information, this like overwhelming just torrent of information. It can be very difficult to distill it down. And it can be very difficult because people do get caught up in these sort of like, well, but I heard about this or I heard about that. Well, what about this? And then, you get into a point where you're just debunking like things rather than getting to the root of the problem.
And I would say, as a pediatrician, it's been really hard. I think Heath and Daniel mentioned this in your lectures, but the misinformation that is out there, and also like the CDC no longer being like a credible medical source that we can go to and like direct our patients to, has also been difficult. And then also just a lot of institutions no longer like supporting DEI efforts, which is why I'm really glad to be at an HBCU at Morehouse because, right next door, Emory, they've already gotten rid of all their DEI organizations. We used to do a lot of collaboration with them. We no longer do that, unfortunately. Um, but it's like at the center of what Morehouse stands for. So I'm grateful to be here.
Awesome. Thank y'all. Did anyone have any other questions for anyone? If not, don't worry, I have another one. So, all right. Um, so you all included great info about taking action or resisting problematic or harmful policies and practices. I was really thankful to see that across all of your presentations. So across issues that were discussed in this session, including medicine, information access, information spaces, both the physical and digital space, mis and disinformation. What opportunities do you believe that there are for various stakeholders to collaborate with those who are in different spaces or different areas of expertise? Because you've all talked about like many different ones. So, thinking of our audience members or myself, who should we be reaching out to that maybe isn't in our immediate sphere? And what opportunities might you be able to expand on for us?
I can go. In terms of workforce development within my field, that has been an issue, a concern. We definitely need more reproductive health, LGBTQ health, trans-based health practitioners. I think a lot of our workforce is scared to engage and scared to become creative and collaborate. So it will be very important for us to engage with some of the personnel and organizations that are friendly to these identities, such as education, training, and research, the Society for Family Planning. Planned Parenthood is a little contentious among various groups, rightfully so. And so it will be important for us not to just engage in these spaces, but also create these spaces. The ones that I listed would be the ones that I trust so far to create those opportunities, but it will be also very important for the next and future generations to create their own.
I think also in like research world, or even if you're not like officially getting like IRB approval and going through that process, and but still like working with communities in some way or promoting things in a community, like really, I don't know, talking to your community that you're talking about of interest, like and I think also trying to in these relationships not be extractive. And like really like if you are working with like an LGBTQIA plus or trying to like work in that group or in that community, and like want to partner with a community organization, like well maybe first offer to like volunteer with them or like see what you can do that is like non-extract, like just really showing up and getting to know the community first before saying okay, and then can I also like do interviews with all of your like staff or something, like really like building those relationships and also coming from a place of like humility where like no matter what you do have something to offer and like can at least like physically show up before trying to like get your piece of what they have or like get something from that community.
And we did get, thank you so much for that, both of you for answering. We did get another question from the audience. If we want to put that, we have about 4 minutes before I'll have to cut, cut you guys out to conclude, but I'll go ahead and put that in the chat, so you can see if either anyone wants to respond to the one I previously asked or this one. I work for an NYC healthcare institution. Oops. On the education side, our marketing team has been conducting audits, and our team has been asked to remove certain links to programs that took place on topics such as DEI and trans health. How do you push back against the efforts coming from the top? And or what are actions we can take to mitigate the erasure? So 3 minutes.
I can jump in really quick on the question that came in. I think that that's a place where it's really, really important to duplicate whatever you can. So back up the data that's being erased and to document exactly what you've been asked to change and why. And I think that that can be part of your pushback against the people at the top is really drilling down into exactly why it is that they are asking you to make these changes and why are they making, why are they asking you to make these exact changes? What is the underlying motivation? Trying to get them at least to admit, to what it is that they're doing.
I can add also one thing I've really tried to do is I guess like because just saying like DEI and any of those words within it has become such like a I don't know like the powers that be get so like whoa. I try to really like stick to using the language of health equity and like because I think I don't know for whatever reason that's like a phrase that I don't think like has really been discovered by these bad actors. Like I just they don't care about it and don't know what it means. But I've been trying to like at least institutionally really be like, okay, well, no matter what, do we still care about health equity? And like we care about like everyone having an equitable access to like healthcare that is life-saving, et cetera. So I don't know, just like one thing I like one small linguistic thing I've been trying to like do that seems to, I think at least um be getting people to realize like no this is about like health equity like it's not like DEI has become so like bastardized with because of all the rhetoric like that we're experiencing that I think like grounding in health equity has been an effective strategy.
I agree with Daniel. I've had to do a lot of language shifting. Um, Language that has assisted me in also developing my data and receiving funding is population health or social determinants of health. We have a lot of the same social impacts as marginalized communities. So receiving funding for those social impacts may be a little bit easier than stating, oh, this is for diversity, equity, and inclusion, and basing it off of a structural lens has really helped me there. I also don't mind being annoying in hospital settings. I am the person that continues to bug and bug and bug until I kind of get my way. So also being adamant and being sure, being difficult, resisting things and not being afraid of confrontation. You have to become comfortable with that. You have to be confident in that and figure out your confrontation style that you're going to say at the end of the day, I was proud of myself in the life that I lived and the things that I advocated for. So ensuring that you engage in that way. And then when I do push back, I often ask, why are we disregarding this population? Then they have to come up with an answer about why this population is not important, why their initiatives are not important, and why this doesn't engage with the lines and fundings that we have. And so those are some things that I find to be important. And those are the ways that I advocate. And also, I use my website to provide that information that may be lost. So Aid Access does provide abortion care and it provides it for free within the pill form to individuals that may need it. Reproductive care is also equally as important. And so those are some of the ways that I combat that. And if I can't engage those things in the hospital, I would love to engage you within my practice. Because if you cannot get it in this social setting, I want you to at least have a setting that does provide that. So that's a little bit about how I advocate in that way.
Thank you all so much. I hate to have you guys stop talking, but unfortunately we are out of time. But so I'm going to do my little closing. So thank you to all of our presenters for your presentations, but also your engagement with each other. And thank you to our audience for attending. We are committed to ensuring that CERT's programs are diverse, inclusive, and free for attendees. In order to do so, we rely on support from ALA, membership, and direct donations. You can help champion our roundtable's mission and commitments by donating at the link provided in the chat and or by joining CERT as a member. You can make a general gift or select the CERT task force or award that you would like to support. Please help us maintain our high quality programming like this, the core values that sustain it, and our commitment to accessibility by making a donation, becoming a CERT member, or helping to spread word about our roundtable and events. Thank you. Our next session today is how inequitable access to care in jails and prisons undermines community health, and it will start at 5:15 p.m. Central Standard Time. We hope you can join us. Thank y'all.